Okay, we're going to talk about problems with the aorta. And a lot of these problems are very related to the topics we just talked about, such as hypertension and atherosclerosis. Those are major risk factors for these. So without further ado, first we have aortic aneurysms. And an aortic aneurysm is an abnormal dilatation of the aorta. So it dilates, gets bigger due to aortic wall weakening. Okay, so remember that the aorta has super high pressure blood, right? And so the aorta needs a really strong muscle wall. It needs that strong elastic tissue, remember that, to withstand all that pressure and to keep its structure. And if that aortic wall weakens too much, it's not going to keep its structure. It's going to blow up like a balloon. And that's what happens in this aortic aneurysm. Now, as you can see here, there's the thoracic aorta, the thoracic area, and there's the abdominal aorta. And the delineating line is right here. It's the level of the kidneys. Okay, so below the level of the kidneys is the abdominal aorta. Above it is the thoracic aorta. Now, there's different pathophysiologies for each. So let's focus on the abdominal aorta. And the key word here is atherosclerosis. This is the main risk factor for abdominal aortic aneurysms. I'm going to draw it out and show how that happens. So this is the lumen of the aorta. We have blood flowing through. Blood is coming through. It's perfusing the media, and it's keeping it healthy. Now, if you have an atherosclerotic plaque here, you are not able to diffuse as much. Okay, there's more stuff to get through. So that blood is not getting to that media. So that media is, if it's not getting blood, it's going to get weakened. And what we say when the vessel wall gets weakened, well, it's going to blow up like a balloon. That's exactly what we're going to see here. So the way this presents is you're going to have this thing in your abdomen. It's big, it's fat, it's going to be pulsating with every heartbeat. It's going to be causing some pain either in the abdomen or the back. And the classic type of patient you're going to see this with is the older male with other atherosclerotic risk factors. And that just makes total sense if you remember that the key risk factor here is atherosclerosis. So what were the risk factors for atherosclerosis? Remember that was age. Remember that it was like smoking, hypertension, diabetes, high cholesterol. All that can put you at risk for having atherosclerosis and developing an aortic aneurysm. And again, it usually occurs below the origin, the renal arteries. And this is a problem. This is a scary thing, an aneurysm, because it can rupture. Remember, if you blow it up too much, it's going to pop like a balloon. And if it does that, you're in big trouble because the aorta is pumping out a ton of blood, and it's the main thoroughfare of all that blood, and it's going to lead to profound blood loss. You're going to get hypotension. And the larger the aneurysm, the higher the risk for rupture. It makes total sense. Okay, just remember like a balloon. Everything acts just like a balloon. So now we're going to look at the thoracic aorta. This is the upper part. And this is a little bit different pathophysiology. So this is the lumen. This is the media. So the main problem here is called cystic medial degeneration. So it's just the degeneration in that medial layer for various regions. It can be due to aging. As you age, you get weaker connective tissue. That's a fact of life. So that's going to weaken. Hypertension can weaken it. Because hypertension will also cause higher beating, beats up the aorta more. Marfan syndrome is a connective tissue disease. So obviously you have weakened connective tissue here, and so the media, which withholds all that connective tissue, gets weakened. The other thing that can cause this is tertiary syphilis, and it causes an obliterative endarteritis of the vasa vasorum. See, it's so hard I can't even pronounce it. So what the heck is this? Well, first of all, vasa vasorum is a network of blood vessels that feeds the aorta, okay? Aorta itself needs some blood vessels, and that's what the vasa vasorum is. And you can get an endarteritis, which is basically inflammation that's going to occlude. So you have inflammation here inside these vasa vasorum, it's going to occlude these vessels, and so again, you have less blood flow to that medial layer, and that causes weakening of the medial layer, and it's going to blow up like a balloon. Now the complication here is an aortic regurgitation, because this is in the upper aorta. So let's say this expands out, and now you have your aortic valves here. Normally your aortic valves keep blood competent, keep blood flow going in one direction. So normally blood goes this way and doesn't go back. But if it dilates, you can see now it doesn't close completely. So blood can actually go back and regurgitate back into the heart. We're going to talk more about this later, but this is a complication of the thoracic aortic aneurysm. So honestly, this stuff, I just think about it as like a balloon, and the key risk factor here is atherosclerosis. Next thing we're going to talk about is aortic dissection. So this is when the intima of the aorta tears. Let me draw this out real quick. So this is our aorta. This is the lumen. I'm going to draw out a layer, another layer. So this is the intima, this is the media. Okay, normally blood just flows along here, minds its own business. But if you tear this intima layer, then blood can flow in here and fill it up. Okay, it's gonna rip and fill it up. And that is a dissection. You just dissected the aorta. And blood's going to come along, spread along the medial area. It's going to form a false lumen. So normally there was not space here. It's just layers of the muscle wall. But blood can push in so high pressure, it's going to create its own little lumen. Now, anything that weakens the aorta can lead to aortic dissection. And the main risk factor here is hypertension, okay? And it's the same idea with the vasa vasorum. Remember what hypertension does to the arterioles? Remember, it causes hyaline arteriolosclerosis. And that basically means that you get plaque, you get thickening and stiffening of those vessel walls. This is the little arterioles of the vasa vasorum. So again, you're thickening, you're blocking blood flow to the aorta, and so that aortic wall is going to weaken. Another thing that can cause weakness is same thing as before we talked about Marfan syndrome, connective tissue diseases. That causes weakness in the connective tissue in the medial layer. So clinical features of this, if you get a dissection, you're going to get a sudden tearing chest pain. So the symptoms are what you would expect with something that sounds like an aortic dissection. It's sudden, occurs very suddenly. It's like a tearing. You literally are tearing the walls of the aorta apart, and it's going to radiate all the way to the back. Now, there's two types of aortic dissections. There's a type A, which involves the ascending aorta, which is this part right here. So type A, fortunately, they make it A and A. And this can lead to aortic regurgitation. I just talked about it before. You can get those heart valves can become incompetent. You can get cardiac tamponade. I'll talk about tamponade later. But this is a big problem. You need urgent surgery to fix this. The other one is type B. This is dissection involving only the ascending aorta. Type B, this is the descending aorta. Okay, and this is not so much of an emergency. I want to emphasize that in type A, you can also involve the descending aorta. It can go all the way down to the descending aorta, but it has to involve the ascending aorta as well. The way you treat this, well, for type A, obviously you have to take them to surgery. For type B, your goal is to slow the progression of this dissecting channel. So the way you do that is you lower the blood pressure. If you lower blood pressure, there's less blood pushing into this lumen, into the empty false lumen, and it's going to slow the progression. Because if you keep waiting, it's going to keep pushing, it's going to keep going, dissecting the whole way down. Okay, so what you do is give them beta blockers to reduce the force of contraction, and you can vasodilate to reduce blood pressure. Finally, we have a traumatic aortic rupture. This is real bad news. When we talked about aortic rupture already, it's all that high pressure blood is going to go out of the aorta and you're going to bleed to death. So you can suspect this in a patient who's, again, doing very poorly. They're in very bad shape. Their blood pressure is super low, and they were in a trauma or a deceleration injury. This is the key here. The deceleration injury is a key cause of causing traumatic aortic rupture. It's something like a car crash where you're going really fast and all of a sudden you crash into something and you stop. That's a sudden deceleration. And it's very poor prognosis because your aortic's ripped up, your blood's flowing out already. You have very little time to live before you bleed to death. So that was it. That was a little whirlwind tour of aortic pathology. Just remember, it's super related to what we talked about with the atherosclerosis and the hypertension. And it all boils down to how those risk factors lead to weakening of that medial layer of the aorta. And the aorta has all that high pressure, and if it has weakened medial layer, then you're going to get some problems.